You want me to press it? Okay, I'll click on it. Gotcha.
Okay. Okay, we're good to go. Now you can stop your screen share, and after the introduction, you will be asked to share it again. Thank you very much.
You got it.
Okay, let's start the meeting. Good evening, good afternoon, or good morning, wherever you are in the world. Welcome to our online conference today. Before giving the floor to our dear guest, I want to introduce our team. I will be the moderator of today's conference, along with Nurul Huda Maria from Pakistan. My name is Nurullah Kösmene. I am one of the residents of the Neurosurgery Department of İzmir Atatürk Training and Research Hospital. I am proud to present this virtual meeting organized by İzmir Online Neurosurgery Platform. These online education meetings have started with Associate Professor Hasan Kamil Sucu, the Program Manager of the Neurosurgery Department of İzmir Atatürk Training and Research Hospital, and goes on with the contributions of all the residents. Also with the contributions of the neurosurgeons who graduated from the same department. I kindly ask you to keep your microphones turned off during the presentation to avoid voice and noise pollution. You can ask your questions not by turning on your microphones, but by writing to the chat part of the Zoom program. At the end of the presentation, your questions will be asked to the lecturer and will be discussed. Mutual discussion is not appropriate for the format of our meetings, so please do not ask for your microphone to be turned on. And now I would like to introduce our guest. First of all, I would like to say we are proud and pleased to welcome Professor Alexander Vaccaro. Dr. Vaccaro graduated summa cum laude from Boston College in 1983 with a BS in biology. He received his MD degree from Georgetown University School of Medicine, where he was promoted with distinction. He earned membership in the Alpha Omega Alpha Honor Society and graduated with honors in 1987. He completed a year of surgical internship at Cedar Sinai Medical Center in Los Angeles, California, and his orthopedic surgery residency was at Thomas Jefferson University, where he graduated in 1992. Dr. Vaccaro completed a spine fellowship at the University of San Diego, California. He earned a PhD in 2007 in the field of spinal trauma. Dr. Vaccaro is the Richard H. Rothman Professor and Chairman, Department of Orthopedic Surgery, and Professor of Neurosurgery at Thomas Jefferson University in Philadelphia, Pennsylvania. He was the recipient of the Leon Wiltse Award given for excellence in leadership and clinical research for spine care by the North American Spine Society, and is the past president of Cervical Spine Research Society, the American Spinal Injury Association, and the Association for Collaborative Spine Research. He has over 900 peer-reviewed and 210 non-peer-reviewed publications. He has published over 372 book chapters and is the editor of over 65 textbooks and co-editor of OKU Spine and editor of OKU 8. Dr. Vaccaro is the president of Rothman Institute, chairman of the Department of Orthopedic Surgery, co-director of the Regional Spinal Cord Injury Center of the Delaware Valley, and co-director of spine surgery and the Spine Fellowship Program at Thomas Jefferson University Hospital, where he instructs current fellows and residents in the diagnosis and treatment of various spinal problems and disorders. And today, Dr. Vaccaro will give a speech about classification of spinal trauma. Welcome again, Professor Vaccaro. Now, please, you can start sharing your screen.
Well, thank you very much. It is an honor to be here with you today. I think this is a wonderful opportunity for different cultures to get together, and I want to thank you for the time everyone's spending tonight. It looks like it's dark in Turkey. What time is it out there?
9 o'clock. 9 p.m. here.
Oh, you poor guys on a Thursday night, so I apologize. So I'll let you get to bed early. So thank you for spending time with me. So I'm going to talk about spinal trauma classification, and everyone comes from a different upbringing. So I came from North America. So when I was going through the training program, my boss was his name was Dr. Kotler, and we used the Denis system, DENIS, and that's all we used. And we didn't use the AO system because that was sort of, Western Europe, so we didn't believe in it. So we used it forever. And there were so many problems with the Denis system because it was a very aggressive system. If you had a burst fracture with 2 columns, we took everyone to the operating room. And that was crazy because you don't have to do that. So it was just, it didn't make any sense. So a bunch of us got together with study groups and we've looked at all the different classification systems. And all authors do is that you stand on the shoulders of someone that comes before you. So everything you're going to see today, someone else invented and we just refined. That's all it is. We just basically took what other people did and we refined it. So my conflicts is that I was on part of 2 study groups. One, the spine study group, and then the other one was the AO study group. So if you look back, when you write papers on classification system, it's easy to do a descriptive classification system. You see what you see on an X-ray, you describe it, and you classify. And then a mechanistic classification is interesting. You look at something that looks like a flexion distraction or distraction extension, and you say, okay, it's a distraction extension, until you do cadaveric studies and you drop a cadaver from the same height with the same mechanism, and all of a sudden different fractures result because it depends on the body habitus, the age of the patient. So they were descriptive, mechanistic, but they didn't prognosticate, they didn't help for treatment. And the ones that were morphologic, no one had any understanding of stability. And that was the thing we griped about. So when I was a resident in the 1980s, you just said, okay, that looks bad. Let's go to the operating room. So no one looked at the bony anatomy. No one looked at they had stiffening spine disease. No one looked at the ligamentous complex. No one really looked at the morphology, and no one put it all together. Now, there was a great researcher that came out of Pakistan that went to Yale University, and his name was Dr. Punjabi. When I was a resident, he was sort of like the god of biomechanics of the spine. And he was the first one that said, listen, it's a combination of different disruptions of different tissues that make something unstable. Now, if you look closely at this, there's one thing you don't see, and that's the neurology of the patient. You don't see the body habitus, and you don't see the age. These are things that are lacking today. But he came up with this classification system, and it got all of us thinking we have to sit down and we have to take the world's literature and find out if you treated something non-operatively, is it going to fall apart? Is there going to be progressive deformity? And will there be a neurologic deficit? And then if you look at the various regions of the spine, and I'll break this up into the upper cervical spine, subaxial spine, thoracolumbar spine, and pelvic region. Well, you and I know, if you look at the upper cervical spine, there's a different classification system for occipital condyles, atlas fractures, axis fractures, C1, C2. It's all over the place. And there's usually 3 parts for every classification system. So the AO study group sat down and said, listen, what is important? What makes sense? Now, a lot of the classification systems you do, not only do they have to make sense, but they can't be all inclusive, so no one understands them, or it is so detailed, no one will ever use them. So the AO system, which I wasn't really a fan of initially, breaks everything down into A, B, and C. Really easy. 1, 2, and 3. A, compression. B, distraction. C, translation. So can we look between the occiput to C2 and use a very simple system, A, B, and C? And that's kind of what we did. We took this sort of AO philosophy. Again, you still have to remember what A means, and you have to remember what B means, you have to remember what C means, but it just made so much sense. And we came up with the classification system that you see here, and we just published it for the first time this year. And it's really simple. And don't even look at the pictures because you'll just get confused. It breaks the upper cervical spine into 3 regions: occiput, occipital C1 junction, C1, C1-2 junction, C2, C2-3 junction. Those three junctions. And then it breaks it up into A injuries, which are bony, which may or may not be stable. B injuries, which are distraction, but there's still continuity of anatomy. And C, very unstable, rotational and translational anatomy. So if you look at it this way, type A injuries, bony injury only, no significant ligamentous tension band or discal injury. They're stable. We usually recommend non-operative treatment for type A injuries. Let's go through the 1, 2, and 3. Remember I told you, 1, occipital condyle, the joint. 2, C1 ring, the joint. 3, C2, the joint. Well, what's a type A injury? So the way this classification is used is you just say, it's a type 1A occipital condyle fracture. Bingo. You know it's stable. You know it's not an avulsion. Or we have a type 2 atlas fracture. Boom, you know it's a bony injury, nothing unstable, you don't do anything about it. Or you have a Hangman's type A fracture. You know it's a fracture without instability. It's so simple. B injuries, well, now there's a ligamentous injury, but there's still continuity. This could be very unstable or it could be stable. Let's take a look. Type 1, you say, I have a ligamentous injury. The alar ligament is disrupted between the occipital condyle and alar. Well, if they're both disrupted and the apical ligament's disrupted, it's unstable. C1 ring fracture, you have a bony tubercle avulsion that could be stable, which it usually is, or it could be unstable. And C2-3, you have a type 2 Hangman's fracture. You see the ligamentous disruption, discal separation, but you don't have translation. And then C, unstable. Occipital condyle, type 1, separation of the occiput, C1, very unstable. C1 ring, significant rotatory subluxation. And C2-3, you could have a type 2A fracture where you have significant instability with translation. You may or may not operate. Most of these you do operate. So that's what we did. We put together for the occipital, and this has been validated. And we asked people from all over the world, from Turkey, to participate, and this paper will be published. So that's how we took all the different classifications. We got rid of them all. There was 15 of them. Now there's one classification system. Now with old classification system, it's not inclusive. So every one of these systems will have modifiers, and modifiers, they just push you to be more aggressive or to be less aggressive. These modifiers can have points, and we have a numerical scale, and you could add more points to it or less points to it. So M1, mid-substance tear transverse ligament, very unstable. Displaced C1 unilateral lateral mass fracture, can be unstable. Significant overhanging of the lateral mass, that could represent a significant transverse ligament injury. M2, well, if you have a significantly displaced odontoid, that may be at a high risk for non-union, M2. M3, you have some comorbidity that makes you not want to operate or want to operate. And M4, vertebral artery injury. Neurology, it's the same for every single classification system. And let me point to you when I say neurology, and we never had this in the past. Sometimes people are comatose. Well, what are you doing? That's an NX. And that's important to know because it helps you treat them. Some people may have a transient loss of function in the field, but now you see them and they're intact. Well, that's important. Something bad happened in the field, or that patient has a big hematoma or disc herniation. Something bad is going on. That's an N1. And if you have a central cord, some people have central cords without cord compression, but we have a modifier, which is a plus for continued cord compression. Now, as we move down to the subaxial spine, I lived and died with the Allen Ferguson system because it made so much sense. I have a flexion distraction injury. I have a distraction extension injury. It just makes so much intuitive sense until we try to validate it. And we found out that things don't follow the normal mechanism. We were dropping cadavers, as I said before, same height, same mechanism, different injuries. And plus there's 24 different classes to this. It gets too confusing. So again, we looked at it. We came up with something called the SLIC system in 2007, and we went back to the basics. I want to know what the soft tissues look like. I want to know what the neurology looks like. I want to know what the bone looks like. And then it's so simple. You describe the level. It's a C5-6. It's a dislocation. Description of soft tissue. We have a disc herniation, and the patient's in Asia C. It makes so much sense. And then with that, you can have modifiers that look at, is it stiffening bone disease, multiple levels of involvement. And then you can come up with a scoring system. And as I said to you before, every one of these things has a scoring system. And then if you're a resident or you're not familiar with trauma, say you're a deformity surgeon, a degenerative surgeon, a tumor surgeon, you don't do it that often, you just kind of use this as a scale. Well, this is I added up all the points and it seems to be pretty stable. I think I'm going to treat this non-operatively. It's not my expertise, but I think I'm going to treat it non-operatively. And then with these classification systems, you can come up with algorithms, and we've developed so many algorithms. So, and you could use artificial intelligence now on an app and take a picture of a fracture. The AI uses a deep learning function to recognize the vertebral bodies, their morphology, and their translation. It automatically classifies them, gives a point, and tells you how to treat it. Now, that's just an educational tool because everyone's different. So it's interesting. So with that, we went back to the basics and said, well, the world loves A, B, and C. Can you take the subaxial system and make it A, B, and C? But we have something different in the neck. We have facet injuries. We have unilateral facet dislocations, bilateral facet dislocations. Can we incorporate that? So we sat down and we came up with a system that is used in the thoracolumbar spine for the AO system. We have 5 different types of A: minor, wedge, split, single end plate, 2 end plate burst. We have 3 types of Bs: tension band through ligament, tension band through ligament and bone, and then distraction extension, and then translational. Very simple. A, minor injury, could be a lamina fracture. A1, compression fracture. A2, pincer fracture. A3, burst fracture, 1 end plate. A4, both end plates. B1, you have bony injury only. B2, ligamentous. And B3, distraction extension injury. And any type of translation, it's a C. And we did the same thing for the thoracolumbar system. But here, we needed to look at the facet joints. So we said, what's a stable facet injury? What's an unstable facet injury? F1 stable, the height of the fracture to the supraarticular process, less than a centimeter, stable, less than 40% of the lateral mass, stable. F2 is unstable. F3 is a floating lateral mass, ipsilateral pedicle and lamina. And 4 is a dislocation. So we put it all together. F1, stable facet. F2, unstable facet. F3, floating lateral mass. F4, dislocation. Now it starts to make sense. And again, same neurology. Take a look. Same. Everything is the same. So it's easy to memorize, but the modifiers are different. And remember, modifiers can have number of values to it, which I won't get into. M1, you think there's ligamentous disruption, but you can't be sure. M2, disc herniation. I want to know that if I have a unilateral facet dislocation and I prepare to do a reduction closed in an awake setting, I want to know if there's a disc herniation. 3, stiffening bone disease, i.e. ankylosing spondylitis. And M4, you could have a vertebral artery injury, which makes you more reticent of putting a screw in the normal side for fear of knocking out that other vertebral body. And again, this is not important, but we have a system where we look at it and we look at the morphology. C's are more important than B's, are more important than A's. So we'll call it an A, and then all the other things like the level and the type of subfractures, because you could have a facet dislocation. On top of that, you can have a burst injury. On top of that, you could have a compression injury. So parentheses tells you what else is going on. Facets, you have right side, left side. So the right side goes first. And then if there's multiple injuries to a facet, anything with the most significant injury, we put. So that's how that works. And then we just took that entire situation and moved it down to the thoracolumbar spine. And we went through the same reasoning. We said, okay, forget about the original AO. Doesn't make any sense. There's 53 different subtypes. Forget about Denis. Forget about Holdworth. Forget about McAfee. What's important in the thoracolumbar spine? Well, what's important is the neurology, which no one talked about. What's important is a ligamentous complex. And what's important is understanding the morphology. And as you can see in that graph on the right side, you have neurologic status. We give points for neurologic status. I can't advance that anymore, but there's neurologic status, motor, and so forth. So we go through each one of those things. And we found out it works great, except for the lower lumbar spine. because L4 and L5 always seem to be stable. So every time we try to validate it, it just didn't work out very well. So we came up with the AO system, which was we used the same mind frame that we used for TLIX and used for the AO subaxial. We have 5 compression type fractures. They're exactly the same. Minor, wedge, split, single end plate, 2 end plate. 3 Bs, bony only, bony soft tissue, distraction extension, and 3 translation. The same exact setup. Then we looked at neurology, memorize it. It's the same. And only 2 modifiers. Do you think there's ligamentous disruption? And again, every time you look at an MRI, you look at a T2 weighted image, it always looks like there is disruption. And then M2, is there a specific comorbidity that may make you want to be less aggressive or more aggressive? And again, like the other systems, we have a point system. What's interesting about this point system is that we gave different numbers to a single end plate burst or 2 end plate burst, because most of the studies have shown that a 2 end plate burst tends to fall into kyphosis more frequently. So that was interesting. So that we did that, and then we gave it, you can see here how we have the modifiers and so forth. So we really, in this system, we took the TLIX system and we refined it. We said, listen, we gave a little more credence to what we think is a stable burst fracture and an unstable burst fracture. And then when we sent it out to the residents and the fellows, we found out it had a greater intra-rater reliability than the TLIX system. So we now have 9 subtypes rather than 4. So it was a little more discerning. So we did that. And then finally, the spine is attached to the pelvis, and spine surgeons ignore the pelvis all the time. So we got together with a bunch of trauma surgeons and said, can you help us understand stability, sacral fractures, lumbosacral injuries? And we divided it into stable injuries, posterior pelvic injuries, and spinal pelvic injuries. So type A, lower sacral coccygeal injuries. Now remember, you can still have a neurologic deficit from a transverse Roy-Camille fracture. So it doesn't mean you can't have a neurologic deficit, but from a mechanical perspective, it's stable. Then you have posterior pelvic injuries, and this is sort of similar to the Denise system. There's no instability between the spine and the pelvis. And then you have the C-type fractures and the U-type fractures, where you can potentially have spinal pelvic instability. So if you take a look at this, type A was lower sacral coccygeal injuries. A1, minor avulsion. A2, non-displaced. And A3, you could have severe cauda equina syndrome at A3. Stable from a mechanical perspective, but neurologically unstable. And then Bs are just like the Denise system, but we named it differently because we decided to name a foraminal fracture in the Denise system that's type 2. We made it type 3 because that has the worst neurologic profile. So 1, central canal has the least amount of neurologic deficit. That's B1, B2, sacral ala, and then B3 through the foramen. And then we looked at the C-type fractures, which are basically U-type fractures. C0, non-displaced. You see it all the time in osteoporosis. C1 is an isolar fracture where the fracture line goes medial to the facet. So you could have dissociation between the spine and the pelvis. C2, bilateral Denis type fractures, very unstable. And C3, the worst of them all when you have displacement. And so we put that together. So now we finally did it all. We went from the top to the bottom. We have a comprehensive classification system. And again, neurology is exactly the same. Neurology, exactly the same. Modifiers are different because it's a pelvis. Soft tissue injury, metabolic bone disease because type C injuries you see all the time in osteoporosis, anterior pelvic ring injury, M3, and then you can have an SI joint injury, M4. So they're all different. There'll be a scoring system. And you got to be careful because sometimes you may see what appears to be an insignificant fracture, but it's not. An iliolumbar avulsion fracture from an SI joint dissociation can be very unstable. So what is the problem with all these systems? Well, do they really prognosticate? Is it just good to classify at the time of trauma? And do we have to re-image these people a week later to see if there's any change in deformity? Do we have to include their balance, pelvic parameters, their SVA? And how does this help us understand the fixation? So these are the things we have to work at. Body habitus, age, frailty, sarcopenia, all that has to be. And these are the things now, as we use big data and machine learning, we'll have a better understanding on. So in the future, we know exactly how to manage these fractures. So future systems, spinal balance, prognostication, treatment guidance. My opinion is that you'll have a system that classifies someone initially for immediate treatment, and then you always have to x-ray them a week later if you decide not to operate on them, and see what they look like then to determine if there's any occult instability. So I want to thank you. I just told you a lot of stuff in the last half an hour. In fact, I'm confused. There was so much data there. So I want to thank you for your time and listening
Thank you,
to my
sir. Thank
understanding
you
of
very much.
classification system.
It was a great lecture. Nurul Huda, you are there?
Unmute me. Hello, yeah, sir, thank you so much for the wonderful lecture. It was really insightful, sir. Thank you so much for the wonderful lecture. And as you have mentioned, sir, these new algorithms have made things really easy and more objective. Sir, I do have a personal point here that there is one thing that we need to consider, that every resident is well versed with these classification systems. So what I have felt during my own training was many of our residents were like a little lacking in the application of such systems, which are incredibly good. So I think that there is a need for all the mentors to make sure that these classification systems are well applied on in the hospitals. And I think that there should be posters, like I had those AO Spine posters at my own home, which I got from I was gifted by an AO Spine conference. So I had those, and those were so helpful. So again, thank you so much for the wonderful talk. Sir, let me ask you question. So there is one question in the chat section by Dr. Muhammad Ali Demirji Karadanes, Technical University, Trabzon Department of Neurological Surgery. He wants to say thank you, and he wants to show you a very warm welcome. He wants to thank you for the wonderful lecture. His question is that, have you ever decided to operate someone who have fracture that better to manage conservatively according to the classification? I mean, do you listen to your small voice that says it will collapse more afterwards, and it is better to stabilize now prophylactically than later? Thank you so much, sir. He
So
wants to answer this question.
yeah, so great question. So this is what happens when you get older. You develop biases, you have bad past experiences where you've been burned. So you start looking at fractures and you say to yourself in your head, I've seen that before, and that didn't go very well for me not operating on it. Or you could say the opposite, it didn't go very well when I operated on it. So yes, I do at times get more aggressive than the classification systems. And you tend to get more aggressive on cervical injuries, facet injuries, and upper cervical spine injuries as you get older. But I also became less aggressive with thoracolumbar burst injuries, because they always seem, every time you put screws in these, it's settled down, screws migrated, screws broke. We got burned in the 80s and the 90s doing one level above and one level below. So I started to treat them in a brace, and I've been very happy with a lot of the burst injuries. So I became more aggressive in the neck and less aggressive in the thoracolumbar junction and distal. I'm pretty aggressive in the thoracic spine, and I don't want anything to move in the thoracic spine, because I mean, you have the watershed area. So yes, at sometimes I do not listen to the classification system.
Great. Thank you so much, sir, for the very elaborate answer. Sir, there's one question from my side as well. Sir, what's your view regarding bracing in geriatric population?
Okay, so every single paper being published now says bracing is not effective.
Yeah.
You can't find a study that says bracing is effective. I still use bracing because you take a nice brace and you make it tight. People always say they feel better. So I use it because it makes the patient feel better, and they want that comfortable feeling. They get really insecure without a brace. So it probably doesn't affect at all the healing, but I use bracing for patient comfort.
Wonderful. Thank you so much, sir. Sir, we have another question as well from Dr. Baran Tasakula. He wants to say thanks to you, and he said that it was a wonderful session. He wants to ask a question that is that possible that is the possible type C injury in cervical spine? I want to ask one question. Is the possible type C injury in cervical spine?
C injuries is any type of flexion distraction, any type of dislocation is a type C injury. It doesn't mean you have to operate on it. I tend to be pretty aggressive with type C injuries. If I have a facet that's displaced, that's a type C, I tend to operate on osteodontoids. I mean, that's something I do all the time. I think it's so much less morbid than a brace. And if I have a flexion distraction injury, I operate. So yes, you can have that.
Great, sir. Sir, Dr. Rikad Ahmed from Pakistan is saying, thank you, sir, for the nice and comprehensive lecture. So he's sending you regards for that. Sir, there's another question from Dr. Nana. She's asking, thanks for the great lecture. I was wondering, do you use the phrenic nerve diaphragm pacing for upper cervical traumas in your hospital?
Yes, we do. Yes.
Great. Sir, thank you, sir, again for the wonderful answers. Another question from Dr. Baran Sekla is, do you prefer firstly to do close reduction or imaging investigations?
So for the first 20 years of my practice, I would do closed reductions without an MRI in an alert, awake patient that I could monitor and do an exam. As I got older, who needs the stress? Like, who needs the stress and the aggravation that you're going to paralyze somebody? So when after practicing for 20 years, I get an MRI first because I don't want to have a bad day. So I think you can safely do it with an alert, awake patient. But number one, we're not as good anymore because we don't see that much cervical trauma anymore because of all the motor vehicle changes and rules. So I would say if you're a young surgeon, get an MRI first. You don't have to, but get an MRI first. Know exactly what you're dealing with.
Thank you so much, sir. Sir, there is another question from Dr. Marco. He's saying, thank you, Professor, for the amazing lecture. I would like to ask you, in low-income countries, would you consider a laminectomy without instrumentation in thoracic fracture?
No, even in a low, because I've seen a lot of those patients fall into kyphosis. So I'm at a referral center in a very poor city. Philadelphia is the 5th poorest city in America. And we have people that come in from overseas that had a laminectomy and they fall into kyphosis, and it is such a difficult operation to fix. So I say no. I always stabilize it. And I know it's expensive. But I think that you may cause instability.
Thank you so much, sir. Sir, there's another question from Dr. Uger. Do you use traction in cervical trauma surgery? And thanks again for the wonderful lecture.
So yes, we use traction all the time. I used to use it to reduce the fractures. I use it on the operative table if there's any type of translation. Because remember, traction at the time of surgery makes the surgery easier. Because number one, you can monitor the patient neurologically, and two, it's just like deformity surgery. If I have a really bad deformity, I'll use skin tape traction on both legs, and I'll put Haloton, and then I'll stretch people out. And it makes the deformity so much easier to operate on. So yes, I do.
Thank you, sir. Sir, there is a little note of thanks from Dr. Umar Sardar Akjul. He's saying, thank you so much for the wonderful presentation. So there is another question from Dr. Edwin Vasfi from Bulgaria. I would like to ask you, what kind of classification can we use in our practice for thoracical fractures? We all know that for the thoracic lumbar fractures, we can use the AO spine DL classification system. What about the thoracic part of the spinal column? We all know that there is also a fourth column that most authors write about, like Benzel in his book on spinal biomechanics.
Right. So in the thoracic spine, you actually have a fourth column, and that's the rib cage. So you got to keep that. We use the thoracolumbar for the thoracic spine, but I always think the thoracic spine is a lot simpler to use because if you have any type of translation, any type of distraction injury, I'm getting very aggressive with it. So we use the AO system for the thoracic spine also, but it doesn't have anything for the rib cage except for the M4 modifier, which we would consider something to add in that system.
Thank you so much, sir. Sir, there is another question from Dr. Moharram Yaziji. Can we use the same classification system for osteoporotic spine? Do we need a different classification system for those patients?
That's a great question. So we just made a thoracolumbar spine osteoporotic compression fracture. And it was headed by a gentleman by the name of Klaus Schnacke from Germany. And the German Spine Society came up with it. And then the AO took it over about a year ago. And we're just about finished. And we're going to start validation studies. So that's very important because you see a lot of elderly people with compression fractures. And it'd be great to have guidance like who needs to have a vertebroplasty, who needs to have a kyphoplasty, who needs to have instrumentation with a balloon kyphoplasty with screws. I'd like to know that. So yes, hopefully it'll be published in the next year.
Great, sir. Thank you so much, sir. Sir, there's another question from Dr. Edwin Wasfi from Bulgaria. He wants to say that I would like to ask all about the burst fractures with retropulsion of bone fragments. Do you recommend decompression if there is no neurological deficit with pedicle fixation?
No. So I just, a long time ago, we learned it gets every young surgeon nervous when you see bad compression. Now, again, I was asked before, do I sometimes see compression where I get nervous? To me, instability is not related to the amount of retropulsion in the absence of a neurologic deficit. But if it's really bad and I get nervous, I may operate on that. I may go posteriorly, distract a little bit to see if I can push it back, or I may go anteriorly. So I usually do not, unless it's really severe, like 90% or more, then I get nervous.
Great. Thank you so much, sir. Sir, there's another question. So we have a lot of questions, sir. You had a wonderful talk. That's why we yielded a number of questions, sir. Thank you so much. May I ask, this is someone, I think that here his name is in Thai language. I cannot actually read the name. Sorry for that because the script is different. Is asking, may I ask the reason why you do not use diaphragm pacing for upper cervical traumas? It seems like they have a potential for ventilation dependent patients. Your opinion would be greatly appreciated as we are about to start it in my own hospital.
I think you said, do we do phrenic nerve pacing? Yeah, we do it. Yeah, so I think he misinterpreted. We do it. So yes, we do it.
Yes, I guess so. Sir, there is another question from Dr. Atilla Kazanji from Ankara University. Ankara İldırım Beyazıt University Neurosurgery Department. Thank you for the great lecture. Do you think occupation of the spinal canal by the fractures may be important for classification of thoracolumbar fractures? And do you prefer to impaction of retropulsed bony fragments in lumbar burst fractures? Thank you.
So we don't look at percent canal occlusion in our classification because no papers were ever correlated with outcome. But if I do have to operate, if it's at the thoracolumbar junction, I tend to go in the front, but I do tamp them anteriorly after I cavitate through a transpedicular approach in the lower lumbar spine. I don't go anteriorly at L4 or L5. So I will go posteriorly and I will tamp the fragments anteriorly.
Thank you, sir. Sir, there is Dr. Sukru Joglar to everyone. Thank you so much for the amazing lecture. Sir, there is another question from Dr. Mohammed Ali. How can we be sure that fusion, that is recovery, is complete in cases without laminectomies, and I can take instruments out, especially in thoracolumbar fractures at younger age groups? Thank you.
So if you abide by the principle of just doing fixation alone percutaneously, and you don't fuse them, I would take the instrumentation out because you know it's going to sag. And the only way to know if you healed or not is getting a CAT scan. You can't tell. So you got to get a CAT scan and follow up at a year. I wouldn't recommend removing the instrumentation for a year. We always do a lousy job in fusing these patients. So if I put instrumentation in posteriorly, I always put bone graft down, but I just thin the lamina. I don't take bone graft in the iliac crest because I think it's so morbid. And they tend to always settle. They always say it goes back to the pre-fixation level of deformity before you operate on them. But that's the only way I tell if there's a fusion. I get a CAT scan.
Great, sir. Thank you so much, sir. So there's another question from Dr. Farhat Herman. He wants to ask, thank you for your presentation, sir. Do we have to need the Astro MRI for evaluating the thoracolumbar injuries? Is it possible to evaluate the thoracolumbar instability just by the CT scan?
Another great question. I've been involved in so many studies that look at CT, look at MRI, CT alone, MRI alone, CT and MRI. You get more information with the MRI. I've had cases where patients have had hematomas that have gone up and down that you never would have known about on the CAT scan because you can't see it. But it's expensive. If you don't have it, don't worry about it. Use the soft tissue windows to try to infer. But an MRI shows me the ligaments. MRI shows me so much more. It shows me bruising within the spinal cord I can't see. So if you have both, use both. But don't feel bad if you don't have the resources, because the vast majority, 90, 95%, you can treat with a CAT scan only.
Thank you, sir. Sir, there's another question from Ayhan Kanat. Many thanks for your good presentation. There are many thoracolumbar fracture classification scales. What is your favorite classification system?
My favorite is the TLICS system, TLICS, that we made before we made the AO system, because that was the first big classification system. That's my favorite.
Great, sir. Thank you. Sir, another question is there from Dr. Ahmed Elane. Is there any role of pelvic parameters in decision-making for the treatment of thoracolumbar fractures without neurological compromise, or conservative versus surgical?
So repeat that again. I didn't understand that question. Say that again.
Sir, he says, is there any role of pelvic parameters in decision-making for the treatment of thoracolumbar fractures without neurological compromise, conservative versus surgical? He's asking about conservative or surgical.
Yeah, there is. And that's why we came up with the point system, because we looked at over 1,000 cases of patients with neurologic deficit, without neurologic deficit. We did clinical equipoise studies, and we came up with that grading system. So if you use the AO or the TLICS grading system, that helps you determine when to operate.
Great, sir. Sir, another question from Dr. Mustafa Ari. Sir, thank you so much for this distinguished presentation. I would like to ask, do you operate multiple separate fractures that you would normally treat each of them conservatively?
Well, when I was younger, I used to think, well, to help the rehab, they have multiple fractures. I think I'm going to operate now because it's more difficult to rehab. As I got older, you know, you're doing this big operation on someone who's critically injured. So I tend to treat that conservatively unless there's an unstable injury. But I think the question is, if they're all individual ones I would treat non-operatively, then I would probably prefer non-operative unless it truly interfered with rehabilitation. And then I'd probably go with a percutaneous, minimally invasive strategy.
Thank you, sir. Sir, there is a question from Dr. Sukru Jaclar. Do you ever use minimally invasive percutaneous screws without fusion temporarily and then pull them back until you are convinced that the burst fracture has healed?
So I do it all the time for flexion distraction injuries. I do it all the time for distraction extension injuries. Burst fractures, I tend to open up and put bone graft down because I know they're going to settle anyway. So I'm not a big fan of percutaneous for burst, but I'm not against it. So as time goes by, I'm not against it. But all the time with the flexion distraction injury and especially in metabolic bone disease, I'm a big fan of it.
It's sir, there is from Dr. Muharram Yaziji. How about pediatric patients? Can TLICS work for them as well?
It can, and it has been used for TLICS. It has been, but a lot of times we treat a lot of these cases non-operatively. So I tend to, the scoring system has to be different because it hasn't been validated in the pediatric system. But in terms of the classification system, it has, so you can use it, but you can be a little more conservative. Like a flexion distraction injury, like a chance injury, I would always operate in that in an adult. But in a pediatric patient, you may be able to get away with just a Jewett brace.
Thank you, sir. So Dr. Ahmed Alani has again said that I think Professor Alex could not get my question. So I repeat again, is there any role of pelvic parameters in decision-making for the treatment of thoracolumbar fractures without neurological compromise, either conservative or surgical?
Maria, I think we can turn on the Dr. Ahmet Alanay's microphone, and we can turn on the Muharrem Yazıcı's microphone because they are president of SRS Society. We must listen them.
Sure,
Okay.
sir. I cannot, I guess I do not have the command. So I think
No.
Dr. Orkun Medical will do that because I'm not the host.
Murat, can you do that? Can you turn on the Ahmet Alanay's microphone first, and then Mustafa Muharrem Yazıcı microphone?
Yes, I cannot do that.
Yeah.
Oh, pelvic parameters. Can you guys hear me?
Yeah.
Okay, so I'm reading it now. It says, are there any pelvic parameters in the okay, that's a excuse me. That's a great question. I didn't know what that meant. I missed that question. So that's where we're studying now, because you don't really know the pelvic parameters before the injury because the person's injured, so they're lying on their back. So that's why I said take an X-ray a week later, and we're looking at pelvic parameters. There's been 2 papers published on it. So I think there will be pelvic parameters. I think you'll look at the Rousseli system, and I think you will look at the pelvic parameters, and we have to see what it means if someone has an increased SVA, if someone has a low Rousseli score, but they have a kyphotic deformity in the thoracic spine that's not consistent with their low pelvic incident and low lumbar lordosis, I think it will have an effect. So that's my hypothesis, and we're just looking at that now. So that's a great question. I didn't understand the question before.
I think we are unmuted. Hi, Alex. This is Ahmet.
Hi, Ahmet. How are you?
Nice to see you. So that was my question. And I actually, after all my studies in the sagittal plane, now I became a little bit more aggressive, considering the, malalignment after the thoracolumbar fractures without neurological compromise. And I agree with you, especially patients with Rizzoli type 1 or type 2s or with the mismatches. Maybe we should not allow them to go into kyphosis. This is, my approach, but we don't have any proof with that. We're also working on that. But I think maybe in the future for the classifications, this should also be, the pelvic parameters should also be included. For
Yeah, and Ahmet, we're looking at that right now. That's one of our projects we're doing. I totally agree.
Hi, Alex. Muharrem is speaking. Can you hear me?
Yep.
Okay. Thank you. It's a fantastic lecture. It's a great overview. I just asked the question about the pediatric application of your classification system. As you know, is in the Dan Hederquist led multicentric multinational studies in the European part. I was the part of this study as well. We just examined the inter-rater reliability of the AO classification in the pediatric population. The results is very promising. It works in the pediatrics. But the question of mine was, these guidelines can be applicable for pediatric patients, as you said, and we have some experience, even in the type C fracture, it's automatically needs to fix in adult population. We still have some good cases, anecdotal cases, but treated with the cast or just simple reduction. That's why my question, how this classification, it works. I mean, we can classify the fracture in the pediatric patients using your system, but my question is, how can we interpret this score? Can we apply exactly? Yeah, that's the point.
Well, so I agree. That was my feeling. I haven't seen your study, but my hypothesis is that you have to change the scoring system to make it much more conservative when it comes to surgical intervention, because kids, you can treat kids non-operatively a lot more frequently than you can adult. So I think that we have to get the pediatric spine surgeons together, neurosurgical orthopedic together, to sort of validate a system that's consistent. Take like 100 cases, use clinical equipoise, all the ones that we say non-operative, we take them away, all the ones you say operative, we move it, and then look at the ones where there's confusion, and then follow those patients over time to see how they were treated. And that's how you can reverse engineer a scoring system to figure out what's applicable to the pediatric population. So that's a great thing. So the clinical equipoise process, and then you use a Delphi methodology where then you show the results and say, the people who are great at surgery operated in this patient. What do you think? The people who are great at non-operative care did not operate. What do you think? And then you see the fractures that you don't really understand. And then you get everyone's opinion. And then you look at how they were treated and how they did. And that's how you back into a classification system, scoring system. That's a great question.
Sir, there is one final question here. Thank you from Dr. Yatkin. Thank you very much for the nice presentation. My question is about contiguous cervical or thoracic lumbar fractures. How can we adapt the classification system for those type of fracture that are both cervical and thoracic lumbar contiguous fractures?
So if they're contiguous right next to each other, you know, that is a modifier. Now, if they're non-contiguous, cervical and thoracic, you have a separate classification, and you would be whatever the scoring system tells you to do, you would do. So contiguous right next to each other, easy to do. Non-contiguous, you know, you modify it. And I've done that many times. I've operated on both the neck and the thoracic lumbar spine. Like in degenerative disease, I'm always worried about the neck, God forbid. Then I'm worried about the watershed area, upper thoracic spine. And then I'm less worried about the thoracic lumbar junction and distal.
Great, sir. Thank you so much, sir.
Well, listen,
Sir,
I had a great
think-
time. This is great.
Thank you so much, sir. Thank you for the wonderful discussion. It was so much elaborate and so much informative, sir. Thank you so much for the amazing discussion and obviously the amazing, insightful lecture.
You're welcome, guys. And everyone, get to sleep. It's so late over there. Get some bed. Get some sleep, guys.
Thank
Okay,
you, sir. I
also-
would like to invite Dr. Hassan Kamil Suju to give closing remarks.
Yeah. Also, I want to thank you, Alex Vaccaro, Professor Vaccaro, one more time. It was a wonderful lecture. It was a wonderful night for us. Thank you again. And maybe we can see each other in real life.
I hope so. I'd rather be there. I'd rather be in Turkey right now.
Yeah. I am in Colombia, by the way.
Oh, that's funny. That's funny. That's awesome.
Okay.
All right,
Thank
guys.
you.
Have a nice day. Bye-bye.
Thank you, sir.
Thank you very much. Bye.